thank you very much for everyone for joining us today. So this is the first of these webinars, which will concentrate on specific illnesses. The MS team have volunteered, and I'm sure it will be difficult for the other illnesses representatives to follow our example. For those who don't really know much about Mobilise-D, I suspect everybody will know about it. But this is really a large project to look into conducting digital mobility assessments, technical outcomes, with a view of securing regulatory and clinical endorsement. It's a 5-year project funded by IMI, started back in 2019, will continue for another 2 years, and it is headed by Lynn Rochester and Dr. Robinhoff, and as you can see, the consortium really is quite large, with multiple partners, supported by industry, and this is really sort of the layout of the webinar for today. So Gavin is going to talk about MS briefly to set the scene. And then we will have the Milan team to talk to us about outcome measures, and then their experience in relation to radar. And then we will have input really from the Italian MS Society in relation to that. And then Professor Comey will take questions at that end from the audience. And then we will have the Sheffield team to talk about the project itself. And then Gavin will talk about the baseline demographics so far. And then we will have a patient who's taking part in the project to give us their thoughts in relation to the project itself. So just to remind you, the MS cohort the study is done in Italy, in England, and in 2 sites in Germany. And we will have really details about really the patients' numbers and so on and so forth, perhaps in the later talk. So the first talk will be by Gavin. So Gavin, it's your corner.
The screen. So what I'm aiming to do is provide a brief overview of multiple sclerosis, or MS for short, for anybody that hasn't come across this condition before. Quite very briefly, the earliest reports of multiple sclerosis in the literature date back to the 14th century, where there's well-documented symptoms in a lady called Lidwina of Schiedam of Holland, who seemed to have symptoms consistent with MS, and she's now the patron saint of chronic pain in the Catholic Church. MS is a rare disease. It's got a prevalence of 130,000 in the UK, which equates to around 1 in 500 patients, although the prevalence has increased over the last 20 years. MS is widely accepted, at least in part, to be of autoimmune origin, where a patient's own faulty immune cells attack their own nervous system, causing damage, or, as in the name explains, multiple scars in the brain or spine. The mechanism of the condition are likely to differ between patients, especially between subtypes, which I'll come to shortly. There's a host of underlying factors which interplay with the autoimmune basis, including genetic susceptibility, and environmental factors, including exposure to Epstein-Barr virus, living at a higher latitude and having lower sunlight exposure in childhood, and also lower vitamin D level. Multiple sclerosis is categorized into several subtypes. Relapsing remitting multiple sclerosis, seen here in the graph on the left, is characterized by episodes of disabling symptoms, which later recover partially or fully, and these are termed relapses. Over time, incomplete recovery from these relapses leads to permanent disability, which you can see there in the graph as each spike indicates one relapse and disability accumulates. This subtype's the most common subtype in multiple sclerosis, and it affects around 85% of our patients. It's more common in young adult females. For patients with this subtype, there's a potential conversion to secondary progressive multiple sclerosis, usually after a patient's had the condition for at least 10 to 15 years. And this is typified by a slow increase in disability levels independent of those relapses. The remaining 15% of patients present with primary progressive multiple sclerosis. That's typified by the slow increase in disability without relapses. These patients usually experience symptoms from around their 40s onwards, and there's no gender discrimination in that subtype. Multiple sclerosis can result in a wide variety of symptoms, either during a relapse or independent of the relapses. Patients have these persistent symptoms. It's the commonest non-trauma cause of disability in working age adults. And symptoms include, but aren't limited to, visual changes, such as acute onset, one-sided painful visual failure, which we term optic neuritis, cognitive dysfunction, particularly difficulty with concentration and dual tasking, but memory can also be impaired. Arm function can be impaired with issues with strength and dexterity and the sensation in our hands. And patients can also experience pain, pins and needles, and burning or lancinating type pain in various areas of the body that can be quite intrusive. Impairment of gait is a major feature in people with multiple sclerosis, and it's been cited to be the most important patient-perceived disability. Impairment of gait may be due to a combination of weakness or sensory loss, which causes problems with joint perception or our ability to know what our joints are doing in space. And also it can be caused by coordination problems. Increasing levels of immobility have been shown to correlate with unemployment, loss of income, rising healthcare costs, and most domains of quality of life. This is all the more pertinent when we consider the demographics of the majority of our MS patients, who all present as working age adults. There is no cure for multiple sclerosis, but there are a few treatments, including the treatment of acute relapses, the management of symptoms, including those bladder and bowel symptoms, the pain I've mentioned, and there's also disease-modifying treatments. These latter medications have come to the forefront of MS management with a rapid expanse in the number of medications available over the last 10 years. The main aim of these treatments is to prevent relapses and slow disease progression, but they're unfortunately not completely effective in all patients. The treatments usually act by suppressing the immune system and are largely required long-term, and therefore cause a variety of adverse effects which can accumulate over time. I'll briefly cover why we need better tools to guide the choice of our disease-modifying treatments, and ultimately better tools may help us find a cure. Current assessment tools include longitudinally reviewing patients' magnetic resonance imaging, or MRI scans, to look for new areas of plaques or these scars which indicate that a condition is active. An example of a plaque or a scar can be seen on the screen with the red arrow. We also review a patient's relapse rate through taking a history and examining a patient in clinic. Lastly, through formal assessment tools, largely which are used in clinical trials of new medications, we can assess patients. An example of this is the 9-hole peg test in the bottom right there, which is a measure looking at the time it takes a patient to move the white pins into the holes in the plastic board and then take them back out again. And this demonstrates hand function quite well. The current tools we have are imperfect, and each of the tools have significant shortfalls. Our most commonly used assessment measure, both in the clinic and in clinical trials, is the Expanded Disability Status Score. This is a sum score of an assessment of several functional domains, many of which I mentioned earlier. This is calculated through history and examination of a patient. Each of the domains is given an objective score, which can be monitored over time, and then the total sum score can be generated. The score ranges from 0, indicating no symptoms or signs of multiple sclerosis, to 10 in 0.5 increments, with scores of 9.5 indicating complete dependence. The EDSS score is used as a proxy for disability accumulation and progression, but it's been criticised in the literature for having a bimodal distribution, as seen here, with insensitivity to change despite a patient experiencing relapses or reporting worsening symptoms, i.e. they experience new symptoms, but they stay at the previous score. It's also non-linear, with not all increases in EDSS score having an equal impact on a patient's life. Additionally, scores from 4.5 upwards are reliant heavily on a patient's walking ability, with scores of 6 and above indicating the use of some kind of mobility aid. However, it's known that almost half of patients with MS who self-report falls are ambulant, and they don't use any mobility aid, meaning they've got a low EDSS score, but are clearly struggle with falls. This makes the score quite a poor representation of mobility and falls. So I'll hand over now to our next speaker.
Thank you, Gavin. Welcome to this webinar. My name is Gianpaolo Brichetto. I'm part of the Italian team on multiple sclerosis. We'll talk about patient-reported outcomes in MS and their use, and let's say look at the future of using patient-reported outcomes. We know that multiple sclerosis is an heterogeneous disease in which different domains could be interested by the disease, and some domains, some symptoms are considered invisible, for example, pain, fatigue, and also cognitive function in some way could be invisible, at least in the first part of the disease. So it is of extreme importance to understand if it is possible to capture these invisible symptoms using outcome measures, and in this context, patient-reported outcomes are a possibility that can be used to understand if there is a decrease in some domains like fatigue, for example, and could be used using patient-reported outcomes. It's a hot topic, let's say. Both the EMA and FDA, so the major regulatory agencies in our world, are taking seriously into account patient-reported outcome measures. And these are the two definitions that are used by, on the left, the European Medicine Agency, and on the right, by the FDA. So patient-reported outcomes for the European Medicine Agency are considered as any outcome evaluated directly by the patient himself and based on patient's perception of a disease and its treatments. The definition of FDA is slightly different. It's any report of the status of a patient's health condition that comes directly from patients without interpretation by a clinician or anyone else. So this also opened the way to, let's say, any report of the status of a patient's health condition could be an active measurement using, for example, patient-reported outcomes, but could be also a passive measurement using also devices that could be wearable devices that could directly set a flow of data without interpretation directly from the patient. In this context, I would like to talk briefly about the experience of the Italian MS Society on patient-reported outcome measures. We started different years ago to collect data in our clinical centers, rehabilitation centers. The idea was to understand if, say, a combination of clinician-assessed outcome and patient-reported outcomes could be used to understand the disease progression. So we started to collect those data every 4 months in a group of people with multiple sclerosis followed by our centers. And as you can see from the slide, I will not go into detail, but there are clinician-assessed outcomes and patient-reported outcomes that are evaluating different functional domains in MS. And of course, the domains related to, I will try to use, okay, I hope you can see pointer. The invisible domains like fatigue is evaluated with the modified fatigue impact scale, that is a patient-reported outcome, for example, but also the dimension of emotional aspects is evaluated in this project with the hospital anxiety and depression scale. So our idea was to start to collect this data and have a sort of register of patient-reported outcomes. And in a first analysis of this outcome in more than 800 people with MS, we started to use machine learning approach that is used also in different aspects of our life. For example, used by major companies to understand our behavior and what we would like to buy, for example. And using this type of approach, we understand that clinician assessed outcome and patient reported outcomes, in particular patient reported outcomes, could be used to detect disease curves in multiple sclerosis without taking into consideration other examination with an accuracy score that is quite high. So our second scientific question was to understand if it's possible not only to detect disease curves with outcomes measured coming directly from patients, from people with MS, but also to understand if it is possible to predict in a certain way disease curves with data collected in fixed time points. So we use the model of machine learning prediction, and our question was to understand if it's possible to, in a certain way, predict the shift from relapse remitting to the progressive phase of the disease. Of course, the data that I will show you are valid in the context of our study, but it's a sort of pilot study in which we collect sample every 4 months in different time point, 8 time points in a group of 900 people with MS, and then we started to elaborate those data with machine learning. And what we found was the possibility to predict in a 4-month period the possibility to be in the next 4 months relapse remitting or shifting in the secondary progressive phase of the disease with an accuracy of 84%. This is, in our perspective, in our knowledge, an important message to, in order to say that data coming directly from patients are important, in particular patient-reported outcome, but not only patient-reported outcomes. Of course, there are limitations. The 2 limitations that, in my opinion, should be considered are: the first one, we have already prompts that are patient-reported outcome measures that are quite effective in measuring what we want to measure, but there is a need to develop more precise patient-reported outcome measure in collaboration, in co-creation with the people with MS. Because it is important, in particular in this type of measures, to understand the perspective of people with MS in order to create this measure. And the second important point is that in order to implement the use of patient-reported outcome measure, but also performance measure that we can collect with wearable devices, we need to shift from a traditional way of collecting measure to digital health. This is something that it is extremely important for the future, and this is the reason why also there are initiatives. In particular, I would like to talk briefly about this initiative that is called PROMS, that is a global initiative in which the European Charcot Foundation, the MS International Federation, and the Italian MS Society in this global initiative are trying to move forward with the science of patient input and patient-reported outcomes, also and in particular in the digital health topic. We will have a question and answer session later. Thank you. I will leave the floor to Letizia Leoccani.
And so I will briefly share with you some thoughts about EPROMs in multiple sclerosis, which are part of the e-health that is generally proposed not only for remote monitoring, which is the discussion of today, but also as a tool for digital therapeutics that we will not deal with today. Even in the field of remote monitoring, there has been a very important discussion about the need for digitalization, also because of the pandemic that had many people distant from hospitals. And so not only for clinical management of people with multiple sclerosis, but also in general for all health conditions, and also not only for the management, but for clinical trials. So also regulatory perspectives need to be addressed. And as Gavin said, most of the measures, even in the assessment of drug effects, are made with expanded disability status scale that, as Gavin said, is not sensitive. And think about the example of people with quite moderate to severe disability, that how the scores are defined. Think about the fact that it is recommended that we walk 10,000 steps per day, which are like 8 kilometers in the metric system. And we started to consider gait impairment when the people start to walk 500 meters, which is really not so much. Think about the worsening of gait from 8 kilometers to 2 kilometers. It cannot be picked by EDSS by definition. And so there is a higher range of mobility changes that could be picked with a digital mobility outcome. Even considering EDSS itself, there have been several attempts to perform EDSS remotely. Again, this could overcome distance from hospital and the need to stay away from infections. But again, EDSS is touched by the physician. So although remotely the patient participates actively to a sort of self-assessment, the final judgment and scoring is given by the examiner. So this is not really a patient-reported outcome, even when performed digitally and remotely. So in the initiative of PROMS, there is a big importance given to the e-health aspects that can enable people with multiple sclerosis to have a holistic and personalized approach, and also to allow passive monitoring, which is a concept that Gianpaolo also introduced, in the sense that with active monitoring, the patient has to participate to the assessment and so is aware of being examined. That can also induce stress and burden of the examination, not only burden of the disease. In the case of passive, patients can do their everyday life and just get measured during their everyday activity, which is also part of a main goal of Mobilise-D. And sensors have been used in many situations, even in people with MS. And mostly in the lab, there are many papers already out that allow also to measure, for example, gait parameters and muscle activation. But we lose a lot if we just limit our measures in the lab. In this example, we use a lumbar sensor to measure gait performance in people with MS, and we found out that walking with socks has the same impact on slowing of gait, similar to performing a dual task. And so a simple change, which is moving from the shoes to the socks, is inducing a big change that will be never picked in the lab if we keep performing the tests only in one condition, while at home it is very well likely that people will be barefoot or with socks. So it's important to follow people in their real activities. And also, as Gianpaolo said, also to listen to their opinions. So it's very important to collect also questionnaires and their voice, which is of course an active collection. And there are several examples also of this type of applications. But in the PROMS initiative, we are performing a landscape analysis in order to collect all the existing initiatives and available data. And so, of course, Mobilise-D approach will be part of the landscape analysis we're performing with Gianpaolo within the PROMS initiative. And among these available tools, there is just one example, which is the Floodlight software, which is also EU certified, that combines the two concepts that Gianpaolo introduced of active and passive monitoring. And it is a software based on a cell phone, so no special sensor added on. But considering the active measures, the 9-hole peg test that Gavin told us is quite important in people with MS, is frequently used measure, is well correlated with the measure of a hand function that is in the app, which is a pinch test, a tomato pinch, and the walking test in the app is correlated with the walking speed that is part of the MS functional composite that we are also collecting in Mobilise-D, as we will see later. And also the cognitive test, the single digit modality, can be, which is routinely performed to assess cognition in people with MS, is also correlated with the similar test that we can perform with the cell phone. But cell phones have a limit, that we don't always wear the cell phones with us. And this is an example from my own cell phone. I don't wear a cell phone in my pocket. So when it's on the table, especially on Sundays, if I go for a walk, you're not going to get my measure of the total number of steps. And if I'm at the beach, I'm not having my phone on me. And so the number of steps will be reliable. And this is proposing the need for having a sensor on the body of the person, as we are doing with Mobilise-D. And also the number of steps is going down, not only because of the disease progression of physical or neurological events, but even by external conditions. And this is my number of steps going down during the lockdown we had in Milan and in Italy in March 2020. So we really need to combine many information, including environmental. And this is bringing the need to add a sensor. For example, there is already in the literature, and Gloria will show us examples of the application of a wristwatch, like the Fitbit, that is capable of measuring also the number of daily steps, and that is correlated with the EDSS that Gavin has presented us earlier. And moreover, the EDSS monitored over time, if stable, is associated with a tendency to a stable number of steps, while worsening of EDSS is also associated with worsened number of steps, reduced number of steps. But as Gavin said, EDSS is not very sensitive, because this is just a selection from the study of Valerie Block that I mentioned, of people with stable EDSS over time. And if you look at the number of steps, even among people with stable EDSS, there is a worsening over time. So this is not picked by EDSS, but sensors could be more sensitive to worsening. And of course, we should not use devices for other purposes. For example, some customers of the Fitbit had performed a class action because they did not detect atrial fibrillation, but of course Fitbit was not meant to do that. So we need to really explore for each device the properties and the features that can be reliably tested or not, measured or not. And again, also the Fitbit measures can be influenced by environmental effects, like I'm showing here the publicly available people mobility measures provided by Google that during the pandemic show a drop in the mobility of people that will be also reflected in our sensors. But sensors were already available and used during the radar study when the pandemic hit the world, and so part of these events were measured also during the radar study. And so I welcome Gloria to talk to us about our experience with radar.
Radar CNS was an MIT funded project aiming at exploring the use of wearable devices for the monitoring of neurological conditions, particularly epilepsy, major depression, and multiple sclerosis. And within Radar CNS, the multiple sclerosis project were led by the Milan MS Center and by Professor Kami, and so the involvement also of the Copenhagen MS Center and the Barcelona MS Center as well. The Radar MS studies had the major aim of determining the usability, feasibility, acceptability, and the adherence to remote monitoring technologies. And also the study comprised two sub-studies. The first one was the disability and fatigue study, whose aim was to determine the usefulness of remote monitoring technology as a possible tool to qualify the disability level of patient and to detect longitudinal changes over time. And the second study was the depression study, focusing on newly diagnosed MS patients with the aim of detecting mood changes after the diagnosis. So this is the MS disability study design, and as you can see, we have been using the Fitbit together with two different applications for the smartphone. One application collecting passive data from the sensor from the smartphone, and the second application collecting active data, that is asking patients to fill in questionnaires remotely. The patients, we totally recruited 400 patients, and each of them have been followed up for up to 24 months. And as you can see, apart from the remote and active monitoring, we were also performing every 3 months the standard clinical visit. And according to the aim, to the first aim that we saw earlier, that is the usability and feasibility and acceptability and adherence to remote monitoring technologies by MS patient. Well, we can see that out of the 400 patients enrolled in the MS disability study, just 71 of them, that is 17% approximately, dropped out. And we can see that the main reason for dropping out, at least a third of patients dropping out, because the protocol was too complex to follow for them, was too demanding for them. Second cause, again, a third of patients dropped out because the effect of the protocol on the smartphone battery life. And when you touch something so important to patient, they tend to drop out, we realized. And a third reason was allergy to Fitbit, but just a minority of patients experienced this. And from this table, you can see that actually there were no significant differences between patients that dropped out and patients that completed the study. And here we can see something about data completeness, and particularly we can see that For passive data, that is what is of most interest to us. We saw two different situations. The first one was that of data stream coming from the Fitbit, such as, for example, data stream of the number of steps and activity. While the Fitbit was well perceived by patients and they tended to wear it during their days without any problems, so the completeness was pretty good. Whereas different was the case of the heart rate and the sleep data stream coming from the Fitbit as well, because patients were annoyed by wearing the Fitbit during night, so this data stream saw a worse completeness. And also, this is the case of some data stream coming from the smartphone. For example, the Bluetooth data stream or the GPS-based data streams were lacking a lot of data because, as we saw earlier, this was impacting a lot on the battery life. Regarding aim number 2, that is the assessment of the usefulness of remote monitoring technology is a possible tool to monitor and to predict the disability level of patients. Well, we did so in the MS disability and fatigue study, and we first did so by using the standard definition of disability progression, that is the increase in the EDSS by 1 point if baseline EDSS was 5.5 or lower, or an increase in EDSS by 0.5 if the EDSS was above 5.5. And we can see here the baseline characteristics of the cohort of patients and the differences between patients that progressed and patients without progression. And particularly, we can see that just age was different between the two groups of patients. And here we can see that patients on the left, we can see that patients that progress according to the standard definition actually walk at in mean a higher number of steps that patient that progress in yellow. And on the right, we can see that also there was a relationship between the EDSS and the average number of steps walked daily. With patients with higher EDSS walking a significantly lower number of steps per day. But of course, what is of most interest to me is the longitudinal analysis. That is, we can see it here that a patient that got worse according to the standard definition, that is the red line, is not that different in terms of slope to the patient, to the group of patients actually, according to the standard definition, remained stable. That is, both groups actually got worse according to the number of steps walked daily along the follow-up. And so we try to examine better patient defined stable by the standard definition of the DSS, and we perform a cluster analysis and we identify two groups of patients. A group of patients actually was stable by the number of steps walked recorded by the Fitbit, and a second group of patients that actually got worse by a number of steps. I can see here in the table that actually the only difference between these two groups was age, that patient with actually progressed also according to the number of steps were much higher than the patient that had no significantly progressed in the follow-up. And we try to use a different definition of disability progression. That is a progression defined by a 20% decrease at 6-minute walking test. And again, here we can see that this other definition does not define a patient that got worse according to the number of steps, because both groups actually got worse in terms of number of steps walked. So it's not a problem of the EDSS per se, but also of the standard clinical measures that are too insensitive to capturing what remote what sensor can capture. And regarding the last study, that is the depression study, and the usefulness of remote monitoring technology as a possible tool to detect mood changes in newly diagnosed MS patients, You can see here the study design. Here in this study, we aim to enroll 240 patients. Unfortunately, due to COVID, we were able to enroll half of them, but the study was much easier for patient. Patient had to remain within the study for at least 6 months, but they could stay up to 24 months. They were wearing the Fitbit as well. But the number of questionnaires and number of things requested from patient was lower, so patient well accepted this study. And you can see here that we had 3 scales as exploring depression in newly diagnosed patient. It is the BDI scale, the IDS, CIDI scales of depression. And we use all the 3 of them to perform a cluster analysis and identify 4 as the number of clusters best describing our cohort of patients. You can see cluster 1 is the cluster with the lowest scores in terms of depression, whereas the fourth cluster is the one with patient the most depressed. And we can see here through a Markov modeling that actually a third of patients after the diagnosis experience a mild to moderate depression. That is, they are in cluster 2 and 3. And we can see in the transition probability matrices that actually there is an adaptation process, whereas patients in just 6 months from the diagnosis, half of patients were in the worst clusters actually got better in terms of mood. And that was the main results from the Radar Siena study. Thank you.
Thank you very much, Gloria. I think, thank you so much to all the speakers. We are open now to 10 minutes of question and answer. I will start with a very practical question, that is, if the slides will be available. The answer is yes. All the slides presented will be available. I think that the first question was about so was the Fitbit data able to predict disability progression in a meaningful way? This is the question to Gloria, to the data that Gloria has presented. So the question again is a bit a central one, has to do with the predictivity of the passive data. So Gloria, what do you say about that?
Yes, for the sake of time, we could not present all the results, but we explore a little bit all the data streams regarding this very aim that is predicting this that actually get worse in terms of number of steps, and patients that actually remain stable in terms of number of steps will get captured by the wearable sensor. And yes, but we have to we had to work a little bit on the data streams and to try to achieve this. That is, we had to transform the data stream of actually we had to use another data stream, not the number of steps, but converting this in a barrel-based measure of steps and measuring actually the speed for each of the barrel, and then we were able to to predict a patient that actually got worse from patient that actually remained stable. Yes, sorry, but not presented the data.
Yeah. So any comment, Letizia or Giampaolo, about predictivity? Giampaolo, you mentioned, for example, that you have been able to predict with of course, not with the passive recording, but with a combination of factors. And here the question perhaps is, which one of the factors had more predictive power? So you mentioned a good predictivity, 81%, if I remember, as a global score. But what about those factors that have more predictive value, leading the predictivity?
It's a combination of factors. It's a combination of factors because the algorithm that we have identified to predict This course is valid only using all the factors that are part of the algorithm. So there's no, but I can say that the factors, if you are looking at the clinician assessed and patient-reported outcomes, are related, of course, to mobility, to fatigue, to cognitive function, but also, and this is something that is relevant, an important part is related to the hospital anxiety and depression scale, so the emotional aspects of the disease. But of course, for the type of analysis, let's say the algorithm is valid only if you are using all the factors identified, without the possibility to identify a factor that is more important, let's say.
Thanks, thanks, Gianpaolo. Letizia, any comment about the predictive power of combination of factors?
Yeah, I think that more than prediction, these tools are very important for detection of worsening or in lucky cases improvements. And so although prediction has of course a very important value to identify, for example, the best candidates for a given treatment, the possibility to detect response to treatment is really improved by the possibility to apply remote monitoring with devices. Of course, I'm very much interested in the confounders of this worsening. And so that's why, for example, I would look forward hearing from Gloria about the impact from future analysis, the impact of environmental factors such as the lockdowns on the worsening and reduction of the number of steps, which of course, if we did the study during the pandemic, or at least across the pandemic, for some patients, this worsening was related to a limitation in the environment and not from the disease worsening itself. So I really look forward to the possibility to combine information.
Thanks. The next question is from Marco Ganzetti. Can you expand on the clustering methodology used to identify the two groups longitudinally? So if I understand the point, I don't know if I understand, but how did you come up with the classification, for example, in progressive and not progressed? Because this is probably the point. Or maybe Marco, if you want to clarify a bit more what you mean. So start, Gloria, to tell us how did you expand, how did you use the methodology to identify the two groups? I think this is by definition.
Yes. No, actually, there are R packages that allow you to cluster according to the longitudinal slope, so that allow you to perform a clustering analysis on longitudinal data. We basically just use that.
Thanks. Next one is the question that is to everybody in the session. Are there more sophisticated gait parameters than steps count or mobility that have the potential to be predictive of the MS course of MS asymmetries, for example? And I think maybe, Letizia, you approach a bit this point. Could you start, please?
Yes, I did. With this question, you get exactly the point of the limitations of step counts and the need for more sophisticated measures, which is the core of the Mobilise-D study. Of course, to answer about the best parameters, we need not only the technical validation study results to be discussed by the leaders of that part, but also results will come from the clinical validation study. exactly to answer to your question. So I hope after collecting the data, we will be able to see what is the best, not only the best algorithm, but the best measures that help us to really monitor the worsening of the people with MS. So thank you.
Thank you, Letizia. Next question is, what kind of thoughts have you on combining data from wellness devices like Fitbit or a smartphone and validated prompts? Have you faced any problem in clinical use? I will start with the Bricchetto now. You have used both.
I think that this is a very interesting question, because at the end of my presentation I was saying that in the future the combination will be probably the use of active or electronic patient-reported outcomes and also passive measurement using wearable. I think that this will increase the possibility to be more accurate in predict or detect what we would like to detect with those data. For example, the risk of relapse. This could be another possibility of an important aspect to detect with those data. There are no in my knowledge, many experiences in clinical use of wellness devices, but in the research use. While the patient-reported outcomes are used usually in clinical activities, I have to say that a problem is the adherence to the use of patient-reported outcomes. In particular, if you are asking to patients to use patient-reported outcomes longitudinally, you need to motivate them, because of course patient-reported outcomes are static and not dynamic. So there is a sort of boring effect that you have to take into account when you're using those type of questionnaire.
I would like to ask on this point, which is a bit the central one, also the comment of Gloria and then Letizia. Gloria, what is your view about the possibility to combine the two, and is there an added value or from this type of combination?
Well, yes, of course. I mean, combining different data streams, of course, will allow to increase the data information that you are processing. So you can, I mean, of course, summarize better the situation of a single patient.
Letizia, you are leading the group of eHealth in the PROMS study, where
Yes.
this is the central point. Any comment?
Yes, as Gloria said in the presentation, and as also Gianpaolo said, it's important to hear the voice of patients, but it's also important not to ask them too much, because questionnaires are can be burdensome. And but of course, to interpret the data from sensors, we need to know what was happening, because otherwise we can introduce confounders and not being able to disentangle them from the real worsening that is occurring. But talking to patients participating to the EPROMs, they really underline the need for more passive measures, because they are very much interested in being ready to provide data, but without being bothered too much and thinking too much of having a disease to monitor. And in this sense, I agree with what Basil is suggesting, that maybe the possibility to provide a continuous collection of data could be important.
And at the very last point, we have 1 minute to react, is the central question. So in the Mobilise-D, we collect the data periodically, every 6 months, in terms of mobility. And in the study, like RADAR, there was a continuous collection. So the point is this periodic assessment losing some information? Where is the trade-off between feasibility and quality of information. I will close with a rapid answer from Gloria.
Actually, we still have to perform analysis to probably respond to this question, but in general, there is a lot of variability in terms of, for example, number of steps. That is the easier parameter to analyze that a patient walked during the weekdays, during the weekends, but also according to the time of the year, for example, during summer or during winter or during a holiday. So it's difficult to say because there is also a high intra-individual variability. So I think this is a parameter that changes from patient to patient. A patient whose variability is lower, so you can subsamples, that is, you record the number of steps a week, 1 week every 6 months, and everything is fine, and you have a clear idea what is going on with that patient. There are patients whose variability is much higher, and so maybe this may have some limits as an approach, but again, we can rely on the radar CNS data to try to explore this question and see the granularity that we need to give an answer in terms of progression to each and every patient.
Okay, thank you so much, Gloria. Thank you so much to all the speakers. Basil, is up to you.
Thank you very much, Carlo. I think the next speaker would be Ellen. She will talk about, introduce us to the Mobilise-D protocol. So, Ellen.
Hi everyone, my name's Ellen. I work here in Sheffield as a research associate. Obviously involved in the clinical validation study data collections, and so I'm going to be discussing today a bit of an overview of the protocol of the validation study, but also focusing a lot on the MS specific items that have already been touched upon by the previous speakers, so it'll hopefully give a bit of context as to what the measures they've been talking about are in terms of this study. And then Dr. Britton, Gavin will be giving an insight into the demographics of our recruited cohorts, sort of, and some of the outcome measures a little later on, just to sort of show where we're up to with all of this. But okay, let's see if I can get this going. There we go. So here's a slide that we've already seen a few times, especially if you've attended a few of the webinars. The whole starts looking a bit familiar. So the total cohort for the validation study is going to be 2,400 participants across 4 different cohorts. We're recruiting 600 patients each. So for our sites in Sheffield, Milan, Kiel and Erlangen, we're between us need to recruit 600. So Sheffield, we've finished our group of 300, and the other 300 is split between the other 3 sites. It's been a massive challenge, obviously, especially since this started May last year, so still in pandemic times really, but we've been able to capture a heterogeneous cohort that reflects the range of mobility and symptom severity in the cohort. At least that's the goal, because obviously then we'll get some really great data for us to be able to show if and whether the DMOs can have value in these cohorts. So the cohorts that we for the whole cohort, for all the participants, everyone has to meet the generic sort of global inclusion criteria in the screening. This means that all of our participants are over 18, able to walk 4 meters with or without walking aids, and obviously are able to consent and comply with the study procedures, whether that be wearing the sensor for 7 days after the visits, returning for follow-ups every 6 months. These are all important parts of whether they're happy to consent and comply with the protocol. And then we also screen against a few different diseases and conditions, just to keep some homogeneity within the cohort. For the MS group, we were also asked a few additional criteria to determine their eligibility. Firstly, where the EDSS score that we've heard about a few times, we ask that that's between 3 and 6.5, so that our participants are showing some disability in a few of the functional systems, but are still able to walk. So 6.5 means they're using walking aids, but are still able to walk at least some distance. And then we also ask that they are showing some clinical evidence of disability worsening over the previous 2 years. This could be in the medical findings, in the medical notes, whether that's on neurological examination or even just patient reports of their worsening. And then we also ask that patients are over 30 days since any previous relapse. This means that between these two items, their condition will be relatively stable, so they're not within the midst of a relapse, but that they potentially might show some great gait disability and progression within the 2-year study period. So it sort of enriches for those patients that will get some hopefully some useful data from, and it'll really show some get some useful data basically. So then once patients are deemed to be eligible, this is the overall protocol that you'll have seen perhaps if you've attended a few of the other webinars. You'll see they've got 5 visits over the 2 years being followed up with every 6 months. We've got some global measurements, and then we have some more disease-specific outcome measures, which is what I'll focus on mostly today. But just to sort of give the context of what everybody will go through, some of these measures are completed annually, others are every 6 months. But essentially, from all the participants within all the cohorts, we'll get their descriptives of age, height, weight, some core measurements like blood pressure. We also ask them all about their quality of life, fatigue levels in everyday life, any falls concerns through measures like the EFPIA International, and the limitations that their condition has on their activities of daily life, through measurements such as the LLFDI. And then we also, through some anchor questions that are reconsidered every 6 months regarding their minimal important difference, address things like their perception of any change in mobility, whether that be the distance they're able to travel, how their speed might have changed, how safe they've felt walking, and how much effort it generally takes to walk. And then as part of the study visit, at each time point, they complete various physical measurements, such as the short physical performance battery, which includes some balance and walking tests. Patients also do a 6-minute walk test and a timed up and go as measurements of their physical capacity, and also their hand grip strength for a strength measurement as well. And then all patients are also sent home with a 7-day mobility, a sensor to wear for the 7 days to do the digital mobility assessment. And that's so that we can capture their real world mobility and compare that to these clinical measurements. And this is obviously one of the main outcomes of the study, is so that we can see how that is changing then over time in relation to these clinical measurements. As I say, for the MS cohort, we have some more specific measurements that are used more regularly in clinical trials. So they tend to be more specific to MS, or are better in this cohort than more global outcomes. These are completed at all visits, so the MS patients have a fair few extra items to complete at their visits than some of the other cohorts. But I'll go through these shortly in brief just now, but then individually, so that you can see what it is we're capturing. So as performance outcome measures, we have patients complete this MSFC, a functional composite, that includes a walk test, the 10-inch foot, the 9-hole peg test, as well as the PASSAT, which is a cognitive assessment. We do another cognitive assessment, the simple digits modality, before doing the low contrast letter acuity. And then, as we've already discussed, we do the EDSS score, which is a quantification of the neurological examination, and is designed specifically for MS. And then we also have a few extra patient-reported outcomes for things that are important in this particular cohort. The MSWS, PDDS, and the MFIS as well, to sort of gauge how the MS impacts their individual daily lives. And then actually specific to this cohort, really we ask patients to fill in falls diaries every month, and then these are reviewed at every 6 months. The other cohorts do this slightly differently, but for us, we have our monthly falls diaries that we ask patients to complete regularly. So going into the performance outcome measures in a bit more depth, as you can see here, this is the items that fill in the MSFC. The timed up and go, the timed 25-foot walk is a short walk where patients are asked to walk as fast as possible. They start from a standing start and they use their usual walking aid. And actually, how changes in this timed 25-foot walk time relate to the digital mobility outcomes is one of our secondary outcome measures for the study in this cohort. To add an extra clinical dimension to the MSFC, we do the 9-hole peg test, which, as we've said, is giving a measurement of upper extremity function, finger dexterity, and the participants are asked to place 9 individual pegs into 9 holes and then back into the bowl within the apparatus. And they do that twice in each hand, and it's timed. And the patients, John will probably tell us later, they have a life of their own, some of these pegs, and they can go off flying sometimes. So if the patient's not careful, so it is an interesting one to try and do. The next test we do as part of the MSFC is the PASSAT, and this is a tricky test that none of the patients enjoy, particularly. It's a measure of cognitive function, and it particularly assesses auditory information processing speed and flexibility, as well as the calculation ability. Essentially, as you'll see here, they are given through a CD recording, which standardizes the test, a number every 3 seconds. So for instance, as the first example, the tape says 5, and then 3 seconds later 2. The patient will then have to say out loud the answer 7 before the next number 6 is given. And then at that point, they have to remember that the last number given was a 2 and say their new answer 8, and on and on and on. So as I say, it is tricky. And so there is also a 2-second interval version that we don't do for this study, as we decided it would be excessive and out of the limits of what was needed. We can get enough from the 3-second. To go along with this, because there are limitations in the PASSAT, we also do the symbol digit modality test, where the patients are given 90 seconds. And essentially, as you'll see in this key here, each symbol relates to a number, and they're asked to read across the page and give us the number that each of these symbols relates to. This is a quite sensitive measure of impaired cognition. And in fact, the page fills the full A4 page, and no one ever makes it to the bottom, essentially, because it doesn't have that cap of a maximum score. Patients just will keep going as far as they're able within the 90 seconds. And so it's a great test of information processing speed, visual scanning, oral motor ability as well. And then the final extra performance outcome measure we do with our MS cohort is this low contrast letter acuity. Essentially, it's able to examine visual disability in a way that, in an additional way to perhaps a Snellen, where it's just a black and white board, is able to, because they are presented with 7 different contrast levels of boards of letters. And so we start off with a black and white board, and then they decrease all down periodically to the final board is a 1.25 contrast, so that we can get an idea of the patient's contrast sensitivity, which is sometimes impacted in MS. Okay, so as we've mentioned as well, we also, as a clinician reported outcome, have the EDSS. We've already mentioned, and you've seen this figure already, the fact that it goes between 0 and 10, but it just to sort of show a bit deeper, it covers 8 functional systems between pyramidal signs, cerebella, including ambulation signs, and whether they're using walking aids, and bowel and bladder function as well. Of course, we're using this to quantify disability at each visit, and at the end, having examined on these 8 functional systems, an overall STEP score is given for that patient at that time, which is this 0 to 10 score. Obviously, for this study, all of our patients will have started off between 3 and 6.5. As I said, that's what our screening criteria was. But obviously, over the course of this study, in the 2 years, we'll see how this will change with disease progression, any relapses and recovery, as well as treatment changes, and how this will relate to digital mobility outcomes as well. Because we also can't go through all of this without asking our extra outcome measures of the patients to see what it is that actually impacts their daily life. We also have added a few extra patient-reported outcomes. We use the MFIS, which is a fatigue impact scale, to determine how their fatigue impacts their daily lives, which is particularly relevant in this cohort, since fatigue is quite common in the population. This looks at fatigue in the last 4 weeks and sort of asks them to decide how much they agree with these different phrases. So between never and almost always. The next one we've also added is the MSWS, which is about walking, and there's 12 measures, 12 different items to say how much in the last 2 weeks has your MS limited these different aspects about walking. Often this one about running gets a bit of a chuckle, because some of our patients unfortunately do really struggle with that, and so they haven't run in years. But so they score between not at all and extremely on each of these items. And the thing with some of these outcome measures is that they either really relate to them or think they're excessive, because they can be very specific to things that actually impact them in their day-to-day life. They're not perfect, and some of them might seem irrelevant, but for the most part, whether somebody is able to climb the stairs or walk without increased effort, or even uses a walking aid inside or outside the home, is really important. And so this MSWS is another one of our secondary outcome measures for the measurements for the study in this cohort. And then the final one we've added is the patient-determined disease steps. So this is sort of similar to the EDSS in that we've got this 0 to 8. It actually is up to bedridden as the scale. But as you'll see, each of these patients are basically asked to consider which one they think best fits their situation. It largely relates to walking, again, similar to the EDSS, but it's how their walking is impacted in day-to-day life. So they can consider if they use a cane sometimes or only out of the house, or if they can manage short distances, but for longer distance they may use a wheelchair, for instance. So it gives them a chance to actually say, this is what I think, and we'll be able to see in the study how that actually relates to the neurological examination, and again the DMOs. But obviously these are all important impacts, important aspects of the patient's independence and daily life that aren't necessarily easily examinable, and you'd hope would sometimes be asked by clinicians. The last item that I need to discuss really is the fact that we do our falls monitoring. So the primary outcome for the cohort is actually the falls frequency during the first 12 months of follow-up. So these diaries are really helpful, essentially so that we can prospectively capture how many falls are happening, and then we review these at the 6-monthly visits, so that we have a really accurate idea of how many falls are really happening in patients' day-to-day life, and whether these are causing injuries as well. Okay, I think that's, I'll throw back to this screen just to give an overview again, but that sort of covers all of our disease-specific measures. Hopefully that's given some context to all of the extra items that we're asking our patients to do. All right. I think it's over to John soon as our patient representative today, but Sharp, I'll hand over to you.
Thank you very much, Ellen, and thank you very much, John, for volunteering to help us try and understand your thoughts in relation to this project. Perhaps if I can just start by asking Carly to introduce herself and tell us a little bit about yourself, if that's okay, and how the MS has had an impact on you?
Yeah, John, I'm 53 years old, a little bit of a daft patient, but yeah, diagnosed with MS in 2006. And since then, my condition has deteriorated to the point where I'd had a secondary diagnosis of secondary progressive in 2014. I've always been very active, and now my ability to do activities has been reduced. Being the person I am, I found ways to adapt to that, and doing various sports at an adaptive level rather than straight out. And yes, it's noticeable that the MS is reducing my ability, but I want to keep going as long as my abilities will allow me.
Thank you, John. Can I ask you why walking is important for you, and why is it more or less important than, you know, things like your vision or your speech or your swallowing or your ability to think or use your arms?
Yeah, it's quite challenging there. Walking is very important to me as an individual. It's you need to be able to walk to do so many things, to do so many activities. I have amputee friends that don't have walking as an option, and they would love to be able to walk. Mobility as a function, it's part of life. Yes, the other things are very important. One of the most frustrating one being cognitive function, you still want that. But the ability to walk, a little bit of that is sort of a prideful approach to be able to walk. I use 2 sticks currently, and I would love to be able to progress, to ambulate without using 2 sticks, because I think that it makes me look like an old man. And I may be getting older, but I'm not old yet.
All right. And we're very grateful to you, obviously, for taking part in Mobilise-D. So what is the most challenging aspect for you as a patient in this project? Is it any of the testing, the commitment to take part in the study, wearing the sensors? What you thought about the project?
And I'll flip that one on its tail. I haven't found anything challenging about the test. Possibly the hardest bit is remembering to tick the box on have I had a fall that day? Where in the centre I found absolutely no trouble with. They're not very intrusive. Maybe a little bit of an issue with them when you're bathing, showering and things like that, but no problems with wearing them any time of day for your normal daily life. They can possibly get in the way a little bit when you're exercising, depending on which exercising you're doing, but it is so small an impact, it can be overcome. So sensor wise, no problems at all. Hardest bit, ticking a box.
All right. So I think we're going to have a little bit of a few questions, perhaps towards the end, if that's okay with you, John. But can I just ask you one final question? Do you think we could have improved in this project if you're really sort of taking part, helping us design it? Is there anything that we should have done differently?
Oh, that's more of a challenge. I was an engineer formerly, so No, as a method of baselining mobility, it's coming up with an effective and convenient way of identifying the baseline. Maybe some of the things you still need to examine is which outcomes you're looking to identify to make that baseline, but it's working well, and I'm just happy to help everybody with this.
We are so grateful to you, John. Thank you very much for your help with the project, and thank you for joining us today. So as I said, we'll come back to you with perhaps 1 or 2 further questions, if okay. So now we've collected some data. Gavin is going to tell us what we've been doing over the last year or so.
Thank you very much, John. Thank you. So whilst we don't have any sensor data available yet, and therefore no statistical analysis of between our cohorts and for our patient outcomes, I've got a brief overview of some of the characteristics we've observed from the baseline clinical data we've actually collected. So we've seen this map before of our target of 600 patients. We've almost reached recruitment, and as of the 2nd of September, which is when all this data is taken from, we've got 300 patients recruited in Sheffield, 230 in Milan, and then our German sites are at 46 and 14 in Kiel and Erlangen respectively. So we're almost there at completion. We seem to have recruited a slightly lower number of female patients than we'd expect. We'd expect in the MS population to see a 3-to-1 gender ratio split, whereas we've got just under 375 females, so just over 60%. The age of our patients is almost normally distributed, with a mean age of 52 years and a standard deviation of 10.8. Just under half of our patients have never smoked, 30% are ex-smokers, and 20% currently smoke. Whilst just under half, or 253 patients, sorry, don't report drinking alcohol on a regular basis. The majority who do drink alcohol do so within the recommended, at least the recommended UK guidelines, which is less than 14 units of alcohol per week. Just over 4.5% of our patients drink slightly more than that, as seen in the end of this graph here. The vast majority of our patients, just over 60%, use no walking aid, with just under 40% using an aid, and that's almost equally split between unilateral assistance, i.e. one stick or a crutch, to bilateral assistance, which can be either 2 sticks or 2 crutches, or a Zimmer frame or a wheeled walker. For our expanded disability status score from our baseline assessments, we've got this brief graph of frequencies of scores across our baseline assessments, and hopefully you can appreciate that the trend follows the expected bimodal distribution I demonstrated earlier in our talk, which is highlighted here in green. So it hopefully is representative of the MS population as a whole. The mean EDSS score is 4.91 and standard deviation of 1.28. Here are the same EDSS scores split into disease subtype, and as expected, our secondary progressive patients have a higher baseline EDSS than our relapsing remitting patients, who tend to have a score lower down in the scale. Primary progressive patients, the number is probably too low to comment on, but they do seem to trend towards the upper range. Whilst the study's monitoring falls prospectively, 333 or 56% of patients reported a fall in the year leading up to the baseline visit. There's a wide range of frequency of falls, with a few patients reporting falling up to once a day, and they're up at the higher end of this graph. 246 or 42% of patients had 0 falls in the preceding year, And the mean number of falls across the year of the entire cohort was 6.59, although there's quite a large standard deviation at 30. If we exclude the patients who don't have any falls, the mean number of falls for those that do fall is just under 1 fall per month at 11 falls per year. This is a graph displaying frequency of falls against our EDSS score. And as we'd expect, patients with higher EDSS scores up at this end of the graph tend to fall more than those who possibly don't have any subjective deterioration in their mobility, or at least objective deterioration in their mobility as assessed by the EDSS score, although they are still falling. When reviewing speed as part of the timed 25-foot walk and split into subtype, it appears that our relapsing remitting patients have a faster pace, which is exactly what we'd expect, with our secondary progressive patients taking just slightly longer. The mean time 25-foot walk across all subtypes was 10.3 seconds, although there's a large range with a few outliers not displayed, which are further up on the right-hand side of the graph. EDSS scores, when compared against the average time for both hands to complete the 9-hole peg test, which again is the test that you've seen Ellen talk about, where you move the pegs into the holes and take them back out again. And as expected, 9-hole peg test time increases as EDSS score increases, demonstrating that hand function declines as severity of MS increases. So in conclusion, with the exception of gender, it appears that the cohort we've recruited so far is generally representative of the MS population, which hopefully bodes well for when our actual mobility sensor data is ready for analysis.
So Gavin, thank you very much. That's really excellent. I think the webinar is supposed to finish around now, but perhaps we could, I think Mara has allowed us a few more minutes really to answer some questions, if that's okay. Question to John: what benefits do you expect for yourself from taking part in this project? Why did you bother to take the trouble of joining us?
Well, I'll be honest, I don't expect any benefits to myself. But if I can help anybody else that's on the same path as me, I'm an unfortunate, actually, or unfortunate for me. I was only actually diagnosed in 2006 with MS a year after my mother was diagnosed in 2005. We're both learning from each other, and if there's anything that we can do to help other people on the process of learning about a disease, okay, we're stuck with it. Nobody's come up with a solution, a fix for MS yet. So let's do what we can to help people out. Nice and easy.
Thank you very much. Perhaps if I can ask Giancarlo, Professor Comey, do you have any concerns about really sort of the cohort in terms of its demographics? Incidentally, I did ask Gavin to tell us who are the smokers and the drinkers, whether the Italians or the Brits, but he refused to answer that question.
Thanks a lot, Basil. I mean, I think no. I see that the distribution of disabilities what is expected. Of course, it always personally, I think that when a person has an irreversible EDS of 3, the person is already entering the progressive phase of the disease. So for many reasons, we continue sometimes to categorize these patients as relapsing, sometimes because it's the only way to give some type of treatments. But what really matters is to have this very large distribution with all different levels that are very well represented. And this is absolutely true. When even when we look at the hand function, again, we have a very good distribution of with all the values represented. So we are in a very good condition to try to succeed, and I think this is the most important message for me. And to John, just to comment a bit what he said, this is fundamental. When we talk to our person with MS, you say it's good if you participate to this study because this is something that is good for you, but is also good for all the other people who are in some way in the same condition and trouble. Is a way to be to feel part of a community, which is really always a fundamental aspect.
Thank you very much. So I see no more questions, and I think we're really almost at the right time to finish. I'm very grateful for all the speakers. I thought that was a very successful webinar. I learned much listening to the talks, particularly from our Italian colleagues.